but I'd become a recruiter for luxury hotels and resorts. And last month we celebrated 20 years. So we're McFarland Hospitality Recruiters. We recruit all over the country and I'll dabble in Mexico a little bit. And it's kept us busy for 20 years. And that's my story.
Captain Michael Schultz with the Sheriff's Office, 8 years. Deschutes, 31 years with Multnomah County Sheriff's Office, having worked the jails, patrol, river patrol, warrants, all those kind of things. And been on the board for, I don't know, how many years have I been, Holly? You recruited me.
Probably like 4
years. And so a little bit about myself. Prior to coming to the sheriff, I have a teaching degree in math science, secondary education, but I was a park director all through high school and college. Best job I ever had. But there were days where I didn't want to go to work because I didn't want to have to play ping pong with all the little kids.
Nice. Peter? Oh, just as I touch it about time.
So, Peter Brown, I'm a retired pediatrician. I practiced pediatrics for 40 some years. We moved here in 1978 when there were 17,000 people in bed. And was privileged to see behavioral health move from a tiny, desperately overwhelmed, chaotic group of people to what you see today, which is a remarkable difference. I got lured into participating in a monthly clinic that the state created where kids would come in and get sorted out. And we lucked out, some of you know Mary Lou Patterson, who is at one point the only RN in the school district. And she ended up being the head nurse, and she would funnel kids in who were slipping through the cracks and not doing well in school. And this little clinic which we lucked out, we had a pediatric psychiatrist, social workers, psychologist, OT, PT, speech, and generally had a good time sorting those kids out. And so I did that, like I said, for 17 years. I am reading the most interesting book called Nexus that talks about a seemingly unimportant topic, which is information and how it gets transferred. And it has a lot to do with the world we're living in now, and it's gripping.
I am Shannon Brister-August. I am originally from, I'm the program manager for Deschutes County Behavioral Health Comprehensive Care for Youth and Families. I came from Washington State, and I've been here since 2005. I guess a little bit about me is, in addition to college and whatnot, I went to Central Washington University, but I spent 20 years in the military. And I moved here after I got off active duty and just put my name in a hat for a position, and the rest is kind of history. So yeah, they decided to keep me. I don't know why.
Yeah, and she'll be one of 2 interim deputy directors starting Monday.
Oh, yes, that is correct. Not till Monday, Holly. Not till Monday. Yeah, so
Shannon, what branch of the Army?
Yeah, it was medical operations, basically operations intelligence and security officer, did logistics. So basically medical planner is what that translates into kind of this world. So yeah.
Cool. Holly Harris, behavioral health director. I have been with the county for going on 13 years. An interesting fact about how I started the county, I started here as a part-time on-call local crisis worker. So I had moved here from Texas, where I had been the director of a juvenile probation department for 6 years. Running that department, loved that work. Moved out here to be close to my sister and her children and her family, and my parents retired out here. could not get a job at the county to save my life. Was applying, not getting even interviewed. Like it was really hard back then. And so I met Terry Schroeder. I met some of you know him. He was the supervisor of the crisis team back then. And I said, I want to work for the county. I knew I wanted to work for the county. I've been a county employee for most of my career. I love local county government, public service. And I said, I'll take, like, what do you got? Like, so I just took this part-time on-call position. Best decision I ever made. It translated into a position on the access team working for Amber, which then transitioned to the supervisor of the crisis team, the program manager of the crisis team, and yeah, here we are. So it's been a journey.
So Amber, listen, we're just doing a quick little something to think about you, something. And we'll do this on a monthly basis just to kind of get to know each other better.
You want me to go? Yeah. Okay. Yeah. So Amber Clay, clinical program manager, and I'll be part of the interim deputy director position here for a couple months with Shannon. Yeah, I came to the county in 2005. So 20 years. I just hit my 20-year mark in April. And when I came to the crisis team, I had 2 people. Molly had just left a few months prior as a supervisor, I think, of the crisis team, and went to Sage View. So when I showed up, it was myself and then several people had just left who've been with the county for 20 years. And I just moved here by myself at the time because my husband couldn't move here yet. And I went, what was I doing? Because everyone had just left and I was by myself with and we did not have a locked PEDS facility. It was a medical floor. Wild. Anyway, I've been here, a long time, and mental health court, drug court were my passions for a long time, as well as the crisis work and adult outpatient work as well, and then access team supervisor about 12 years ago now was the access team, and then been the manager now for about 3 years of access team and clinical admin support and lots of projects. So, yeah. But I've always worked for community mental health programs even prior to coming to Deschutes County.
Kristen, you want to go? And then we'll get Linda when she has a chance to sit down and camera. Synopsis of. It's just one little personal, professional, doesn't have to be have related to something we wouldn't know about you unless we asked.
Well, let's see. I'm program manager. I've been with Deschutes County almost 3 years. Came from community mental health programs, mostly in Southern Oregon and Portland area, and a bit down in California, Northern California. Worked in a variety of different, with a variety of different populations. Worked in Portland with immigrants and refugees. And then in California with the domestic violence and sexual assault program. And then as the director of an outpatient program in Medford prior to coming here. So I've done a lot of different things and been in the field for a long time. That's about it.
Hey, Wendy, would you like to go before I put something?
I totally forgot about. I did see the agenda, but I forgot.
It can be quick. It's meant to.
Cameron Fisher, she, her, advisory board member, and something I like to do in the summer is when I can get the safety support is stand up paddleboarding in waves. What is that called? Stand up.
Surfing?
Yes, stand up surfing in the river.
Nice. I see my nephew out there all the time.
It's a learning opportunity. But when you go out, on different rivers, you need to have safety people who are near you in case.
Yeah.
Not just at the wave, right?
Safety people near me when I wade into the river.
Me too. Even in the ocean.
Linda, so we're just doing on a monthly basis something quick, and you don't need to. We'll have plenty of time to keep adding on. So something interesting about you, personal or professional.
I apologize for being late. I was in your classic, you're 45 minutes late for the doctor to show up.
Oh, yes.
Thank you for that. Linda Nolte, I'm an adult foster home provider. Been doing it about 13 years, my husband and I. Our particular resident is an adult IDD diagnosis and mental health diagnosis. And we're in Redmond.
Everybody in the room? Who do we have up there? Evan?
Yeah, Evan Namkung, Program Manager of Forensic and Acute Services with County Behavioral Health. Let's see, something about me that people might not know. I have a full pack of dogs. I have 4 dogs.
Oh, and Evan's an incredible artist.
I was gonna say, I actually was gonna call that out about Evan too.
I was gonna say, I mean, if we have to do something new every month, I gotta save some.
Okay,
stuff for
okay, we won't
future
take
months.
next month by surprise, but okay.
But the thing behind it,
Yeah,
I mean,
like,
come on,
it
like,
may or may not be murals all over town.
all over town. Sorry, Evan, but
All right.
We're proud. I know, we are proud. You don't meet somebody who can do that kind of stuff every day.
Let's get Molly.
Hi guys, nice to see you. Oh, it's echoing. That's weird. Okay, so I'm Molly Wealth Darling. I am the Senior Behavioral Health Director for St. Charles Health System. I've worked in behavioral health for about 31 years. 27 of those years have been here in Deschutes County, either with Deschutes County Health Services or with the hospital. So I'll just do one thing. So many people in that room know so many things about me. So some of you, but I'll use Rumpel for this one.
yes, you're Rumpel.
For the other people in the room that don't know. So I have Rumpel. She's a pet pig that lives with us in our house. It's up on our bed. She's perpetually 2 years old, and she's kind of Facebook famous, at least with colleagues and friends here in Deschutes County. So that's me.
Her name's Rumpelpixie. And she throws tantrums. And Molly needs to give her own Facebook page. I've been saying it for years.
She's the boss of all bosses.
Yes, she is.
Thank you, Molly. Dana, I skipped you and I'm sorry. Your turn.
I was kind of hoping I'd fly under the radar. Dana Murray, I'm the Administrative Assistant for Behavioral Health. I did not know this was happening. You did not read through so I'm prepared. But something about me, I guess, I used to live in Southern California for 7 years. Moved there all by myself. It was a really good time. Went to college down there. And I also did some marketing internships and thought that was going to be a path, but then I didn't. So. Stephanie?
Hello, I'm staying off camera because I'm sitting here with my son and he tends to pipe in on my Zoom calls. I'm Stephanie and I am a parent of an adult child who experiences IDD and with lived mental health experience. And so, good thing my camera's off. He's totally into the screen. He likes looking at all the people. So something about me, I don't have any professional experience in the mental health environment. I bring the lived experience perspective of raising a child with mental health needs. But I grew up in California, and when I was in college on the pet line, that is, or along those lines of pets, I was a sucker for animals. And in California back in the late 80s, early 90s, and maybe it still is this way, but I moved up to Oregon in 93, so I don't know anymore. But there was always, like, you go to 7-Eleven, of course, because I was a college student, so I lived at 7-Eleven for food and, all those nutritious things. But there was always like cats or dogs, puppies in a cardboard box that people were like giving away for free. And I was a sucker. I couldn't walk past one of those without bringing home an animal. But I was a college student living in college housing, which is a big no-no. So then on the weekends, I would drive to my mom's house, lived on a farm, and bring her animals. And so that was kind of like the running joke. Every time I came home from on the weekends, she's like, "You didn't bring any animals with you, did you?" So fortunately, I grew out of that phase. Fortunately for my mother. But anyway, that's my little tidbit.
Sally.
Hello, everybody. These have been so fun to listen to. I feel like I've learned so much about everybody. So great idea. Sorry, I'm not on camera. I'm taking the call from my car today, so want to be safe. Some fun things about me. I actually grew up in Iowa in a really small town. I grew up on a farm, which was pretty neat. Then I moved to Florida where I got my master's in applied behavior analysis, which is a pretty unique niche of the behavioral health field. And then I moved to Washington State where I lived on Little Whidbey Island. I don't know if anybody's ever been up there, but it's pretty neat. Lots of whales and trees and eagles. But that's where I did my first clinical role. And then eventually ended up moving to the Portland metro area where I practice in Vancouver, Washington. And then I moved to Bend about 3 years ago just because I was hoping to get connected to a smaller community again, similar to Iowa. And yeah, just excited to be here with all of you today. So thank you.
Nicole.
Hi, everyone. Sorry I'm not there in person. I'm Nicole Von Leven, the program manager for the crisis team with behavioral health. Been with the crisis program for almost 7 years, I think, maybe 8. I'm losing track. Prior to that, worked with kids post or pre-hospitalization up in Portland, and then prior to that with men post-prison who had committed sexual offenses. So it's my work history, and one interesting thing that many people don't know about me until they see me drop my insulin pump is I'm a type 1 diabetic. So if I'm eating candy ever, that's why.
So Lee, you're last, I think.
Hi, I am safely almost there. My name is Lee Butler. I'm the co-chair. Also have lived experience with a family member accessing services, and professionally, drug and alcohol counselor at Redmond Treatment Center. Started off in the field in 2012 doing wilderness therapy, so fire with sticks, direct care with the kiddos in Idaho. And then spent about 10 years at Rimrock Trails residential with those kiddos in Prineville. And then moved over to Bend at Bend Treatment Center for OTP, and then did counseling and clinical supervision, and then moved to the counselor role to help facilitate opening the Redmond Treatment Center, which has been around for about 2 months now. Fun facts about me. I do like Star Wars cosplay stuff, and the Mandalorian group that like goes to Comic-Cons and Dornbeckers, the cancer awards, like I do that stuff.
Awesome. Did you love Andor?
That's for another. That's too long. I'll talk for.
What? Oh, no, I know, I couldn't.
I
just finished Andor and I'm like obsessed now. All right, I think I got everybody. Did anybody get skipped over? Okay, we're gonna move on to approval of the April minutes. I think Dana sent out a copy of the minutes. And so I would ask, I think that we need to revise those minutes because there's a couple action items on there that aren't reflected. We have the motion and the second, but I think we have to add the actual vote. And so I would like to propose that we revise the minutes so that the approval of the minutes part reflects that the minutes from March were approved, that the delegation of authority to the advocacy committee chair, which is Danielle, I believe there was a vote and that was approved. I don't think we took any action on the drug and alcohol and drug use planning committee. We'll talk about that today. And then I think there was a motion and a second to add, to recommend to the county commissioners to add Molly to our board membership. And I think that that was postponed so that we had the opportunity to meet her and she's here today. So that's my take on the minutes, but if we have a motion to approve the minutes subject to any revisions?
I second the motion with your additions.
With my additions. Do you have a second? A second. Okay. All in favor, say aye. Any opposed?
Aye.
Aye, okay. All right. So we're gonna move on to the introduction of Molly Wells Darling as a potential BHAB member, and I'd like to ask Cameron and Peter to introduce her since you guys have spoken with her and interviewed her. Do you guys mind?
I didn't hear what you said. Sorry.
We're talking about approving or recommending for approval to have Molly join our board. And since I think you guys.
It was actually just Molly, it was just Stephanie and me
Oh, okay.
and Molly, the three of us.
Okay, that's right.
And Stephanie, feel free to chime in, but we are thrilled to have Molly join the BHAB. Yeah. Lots of great experience and strong connections to most folks in this room and long-term resident bend, it sounds like, in various areas with St. Charles, the county, and a couple other opportunities that she's been involved in, and we just were really impressed and enjoyed talking to her.
Molly, you already introduced yourself a little bit. Would you like to add to that?
I mean, I could go through I could go through my career stuff, but I don't think I will. And if most people know me in the room, if people want to hear that, I'm happy to do that. But in interest of time for you all, I'll just say thank you. I'm thrilled to be here and appreciate being here.
And you're interested in joining us on the board?
Absolutely.
Okay. Do we have a motion?
We want to see if Stephanie wanted to add anything.
Oh, I'm sorry, Stephanie.
Okay, sorry.
Yeah. Did you want to add anything?
Oh, thank you. No, I don't. I didn't. I don't. I just want to second Cameron, and that we both were really, really impressed and would love to have Molly be part of BHAB. So I'm glad that Molly, you were able to join us this month. Thank you so much.
Thank you.
Do we have a motion? I think that the motion would be to recommend approval to the EOCC rather than because that's the logistical order of events.
I'll make a motion to recommend Molly Starling to EOCC for joining BHAB.
We have a second?
I'll second.
Thanks. All right, all in favor of inviting Molly to join us through a recommendation?
Aye.
Aye. Any opposed? All right. Molly, we're thrilled to have you join us. So we appreciate your interest.
Thank you, Molly. And just so you all know, Molly does have to jump off because she's doing me a huge favor in that we are request for capital construction request with the legislature for the child psych facility is up for testimony today. It was supposed to be up last Friday and I was ready, but they all got postponed. And so I couldn't do it today, so Molly's doing it for me, and we'll be jumping off to go do that.
All right, Molly, thanks for joining us today. We look forward to having you at the upcoming meetings.
Good luck, Molly.
Thank you all.
Thanks.
All right. Next item on the agenda is further discussion about the Alcohol and Drug Local Planning Committee, which is a requirement, as you guys know, from by statute that each county has to have that. I understand from Holly that typically it's the BHAB groups from different counties that kind of bring that in. I know that there was some discussion about whether that fits within our jurisdiction of behavioral health because it has to do with drug and alcohol monitoring. And Holly and Lee and I, or Holly and Dana and I met and talked a little bit about the fact that we have I think a proposal, which is to create maybe a subcommittee that I think Amber and Kristen.
Actually, Kristen and I was going to say Callie.
Oh, Callie, that's right, Callie. I'm sorry, I was looking at Amber thinking, okay, that's right. They attend these monthly meetings at Pacific Source anyway, and so it wouldn't be much of a lift for this group to have them keep doing what they are already doing, attend the meetings, and then come back on a monthly basis and give us a quick 5-minute rundown about what happened, and then that allows behavioral health to check off that box. We're in compliance without adding to the burden of this board. Not that it's a big burden. So that's kind of the proposal. Open it up for discussion if you guys have any other thoughts about that.
Yeah, my hope is that, over time, I think we've kind of got a compliance issue right now that we need to solve. And then we've got, time, hopefully over the next couple of years where we can see how that evolves and where it can become a more meaningful activity where maybe activities from the other group that's meeting, can inform some of the work we're doing and really be strategic about how we implement it. But I think starting out of the gate, I don't think we want to propose any major lift for this board to take on that work, but more just coordination.
I see it as kind of a temporary thing, and then it doesn't mean that we can't shift it to some other group as appropriate, but I'd love to alleviate Holly's burden and the new interim directors to have this off their plate and we're in compliance. So any further discussion?
I just wanted to share that I thought it was nice last time to have a little bit about discussion of what behavioral health encompasses and bringing up again, it really is kind of a broader term nowadays to include substance use, mental health, IDD, process addictions like gambling, things like that. So it's really broadened and not just mental health. So I think it's really good for us to consider, you know, what is this board focused on and how do we broaden kind of the scope. So it's nice to have this liaison with this other group and kind of see how it goes.
Yes, I'd be curious if Callie is open to, because Kristen and I talked about it.
Yeah, Callie, we're about it.
Okay.
First time she's here.
I haven't had a chance to connect with her yet because I missed the last meeting, so.
Yeah, and it would just be, I mean, it only needs one of you guys to sort of report. You can divvy it up as you want. And to Amber's point, we talked a lot about that I think that there is some confusion about kind of how substance abuse relates to behavioral health. And I think we have a plan for maybe the June meeting to kind of provide a little bit more insight onto that, because I think it's important so that we all understand why it's sort of blended together. So Callie, are you okay with that?
Yeah, no, I think it's a great idea. I had read the minutes, so I knew that this was going to come up today. And thinking about it, I think it is a great liaison between mental health and substance use disorder. And we just learned so much in those forums about like what's happening on the ground for other organizations that are connected to this work. So, you know, the housing organization, the peer support organizations, like the justice system. So I think that space just does a great job of different perspectives are there together. And then we can kind of bring it back to a more behavioral health focused group.
Great. So I am looking for a motion from somebody to, I don't know how to word it, to bring, to have BHAB serve as the Alcohol and Drug Local Planning Committee with, as we just discussed. Is that right?
Yeah, to designate the BHAB as the local alcohol and drug planning committee. Really.
I'll make a motion that we blend the two together for now, and bring in the other segment with our committee and see how it goes. And
designate BHAB to be the local planning committee.
yes, for the other part of mental health, which includes substance abuse and all that good stuff.
Do I have a second? Second, okay. Any further discussion on that? All right, put it to a vote. All those in favor of this motion, say aye. Aye. Any opposed? Sorry, I'm rushing through it.
Do we have a date planned for revisiting that relationship and looking at how it's working?
No, we don't have one. I would propose that we just kind of see how it goes. And then if anybody wants to propose something different, like if it's not working, then just let me know and I'll put it on the agenda. I'd rather do it that way than, because I don't know how this goes. So I don't know that I want to put a date on it. But if you guys feel like it's not, and Callie, if you don't think it's really working well, or if it's not a good fit for some reason, or if anybody else has some concerns about the way it's going, then just send me an email or give me a call and I'll add it to the agenda for further discussion.
Okay. Just a quick, simple question. So if it's working, what would we observe or experience that would let us know it's working?
Well, I think that there's two prongs to that. I think that Callie and Amber would just be giving their, Kristen, I'm sorry, Callie and Kristen would be giving their, monthly reports to BHAB just to say how it's going. So their input would be one way to measure it. And another way is to find out how we feel as a board. They're not technically board members, but we're ones receiving the information and hearing from them. So I think that we can talk at any time. If it's, if you have different measurables, let's just see how it goes for the time being. And then if it's, I think at the very least, it's useful for them to come and report to us what another community organization is doing that does impact behavioral health. So does that work?
Works for me. Yeah. I think also one of the goals is to really help inform this board of all of the things related to substance use that overlap with the mental health side of things. And so I think we had hoped maybe at a future board meeting that we can talk about what we're doing for behavioral health in Deschutes County around implementing a co-occurring disorder program, a 2.1 level program that's going to be brand new, and I think would be really great to inform all of you of that because it's co-occurring between mental health, substance use, and it's very much in line with what we're talking about today. So I was going to tell you about that, Kristen. Presentation. Yeah. But we'll let you know when. But the same presentation you've done, the one you've been doing. Yeah. Yeah, absolutely.
All right, I think we're good there.
Thank you all, appreciate it.
So we'll move on to the director's report and turn the floor over to Holly.
All right.
Lots to report.
Great. Commissioner Bone is not here today. He had a family situation. His father passed away, so he is there for his service. So that's why he's not here. But we had our budget hearings this week, so that's a big deal. Health Services presented on Wednesday, and our budget hearing went really well. We did not have any asks this year. We're tightening belts like everywhere else, thinking conservatively about our fiscal approach going into next year with knowing there's some uncertainty that we're likely going to be facing, possibly some cuts as well. So we were really just trying to move forward with what we have. And so there were no special requests, there were no asks. Had a good discussion with the budget committee and it went about as smooth as it could go. So that's always a good thing. Yes, so we are through with that process, which is wonderful. We had one really exciting update in that the day before that budget hearing, I received some really wonderful information from the Oregon Health Authority. They gave us a letter of intent to give us $3 million towards the child psychiatric facility. So that's huge. It will help us move that project forward. We have to work out once I get the money in hand, then it's official, because right now it's just a letter of intent. But the Oregon Health Authority has been a really wonderful partner with us on this project, actually, and helped us move this forward in a way I don't think we could have done without them. So we're really, really grateful. In addition to that money, we've also received $750,000 from the Central Oregon Health Council that St. Charles has actually received. We're going to receive the $3 million. St. Charles is going to receive the $750,000. We have all these other requests out there too. So if those play out, they'll be fully funded. But either way, even with this $3 million, we should be able to move forward. So this is very exciting, and I'm feeling as hopeful as I've ever felt on this project. Again, until the money's in hand, I'm not celebrating yet. But
it's a residential facility.
It's a 15-bed subacute facility that will be likely in Redmond, and so that's the only of its kind in our region. It will serve primarily Central Oregon, but also Eastern Oregon. I mean, we're required to take referrals from all over the state, but there's such a need here that I suspect it will be primarily used for children here.
And Holly, will that be ages 5 to 18?
17. Okay, yeah, so cutoff is 18, but yeah.
Yes. So it's, we're going to work out where, getting the money was sort of the first thing, and then we'll get really detailed into the programmatic and design and all of those elements. There's some stuff in the legislature right now and rules around licensing and regulations related to child facilities. So we kind of need to see how that all plays out before kind of fully plowing ahead. So Shannon was actually just in a meeting right before this on some of that. So there's a lot in flux, but good news is that the money's there for us to move ahead.
Very good news right now.
Very good news. Yeah, one thing I'll say, is despite everything else going on and the uncertainty and the landscape ahead, we have added more residential capacity for our community than we've seen in 20 years. So we are between the 2 adult foster homes that I've talked to you all about, the secure residential treatment facility that's under construction right now in Redmond, and the child psych facility. I believe it's like almost 35 beds. So, it's pretty significant for a community our size. We will fill that impact, and it will be substantial. Not to say we can't still use more, because we can, and those will probably be full pretty quickly, but it will provide enormous relief and better outcomes for the people we serve.
How many beds do you think we need in Deschutes County to serve the need completely?
I've been asked, that's a tough question to answer. It kind of depends on a lot of factors. If we had access to the state hospital at the level we needed to, we wouldn't need as much locally. If the aid and assist population weren't skyrocketing, we wouldn't need as much. If we're kind of taking the totality of what we need now, I don't know if I could even guess. It feels like whatever we would bring in, we would fill at this point. because of all those factors. So I'd almost rather wait till we resolve some of these systemic barriers, and then I think if some of those things got resolved, what we've created now, and maybe with the addition of maybe another SRTF, would probably have us in pretty good shape. But it's hard to know right now because the numbers just keep rising. So, any other questions on those two things? Just quick, I think most of you already know this, the Health Services Director, I'm going to remain in BHAB, so I'm going to continue to keep coming here. Monday is when I begin my interim role as Health Services Director. I'm overlapping with Janice for 2 weeks. She is officially gone as of May 30th, end of day, May 30th. But I'm going to continue to come here. Shannon and Amber will be my backup in days that I can't make it. We are going to be in this period for sure, at least till July 31st. Suspect it will go beyond that. We are still very much in the recruitment phase of selecting a new director, and who knows how long it'll be. So Shannon and Amber are going to be taking over as of Monday as well. One big thing that I'm pretty heavily involved in, and for those of you that have been on the board a while, you probably heard me say this 2 years ago, when we were in the middle of our negotiations with the state around our contracts to fund behavioral health. So as you know, there's a lot of general fund that goes to the Oregon Health Authority that gets passed through to us that funds a large majority of the behavioral health services we provide. Every couple of years we negotiate that contract. The last couple of years has been difficult, to say the least. And so one of the issues that came up 2 years ago was in the Oregon administrative rules, it says that all these things shall be provided by the community mental health program subject to availability of funds. Assuming there's enough funding to do all of it, all these things will happen. In our contract, it used to say that as well. 2 years ago, the state took that out of our contract and just said, you should do all these things even if there's not funding. Well, we obviously fought very hard on that. And we're like, we're not signing a contract where we're guaranteeing to do work that we're not paid for. We won that negotiation. They're doing it again this year. So we're back in that moment of like, really difficult conversations. And so there's always a risk in these contract negotiations of what the outcome will be, but we're right in the thick of it. So just wanted to keep you apprised of that. I don't really know which way it'll go. I mean, it's a big deal not to sign a contract. It's a big deal for all of these things to happen. I'm still hopeful we're all going to work it out like we did last year, but that's something in case you hear about it elsewhere. That's a topic that I'm along with every other CMHP director.
Holly, is that a statewide issue?
It's a statewide issue.
So the state is wanting the counties to do this work regardless if they pay for it.
And they particularly, it's almost every contentious issue that we face that's related to the state has to do with aid and assist. And Evan can attest to this, having the manager over this aid and assist. Aid and assist has really had this domino effect of the state is at risk of being held in contempt of court for not being able to adhere to the guidelines related to that population because they are not getting people into the state hospital in a timely manner. So because they're not following statutory requirements, they're at risk of being held in contempt with a $400 million fine hanging over their head. So as a result of that, the pressure gets pushed down the system. And so one of the areas they want us to continue to be able to serve the aid and assist population, so people who've committed crimes that cannot aid and assist their defense attorney in their own defense. That's what I'm talking about. That they want us to make sure we serve that population no matter what. And they know, everyone knows, we've had a cost study. We're underfunded for that service. We are not fully funded to provide the level of care that's required. So I get why they're doing it. They're under a lot of pressure, and to push that pressure downhill on community mental health programs is the right approach.
And I think, and I don't want to take over your story, but state hospital, if you don't know, the reason why they can't get anybody from in the community of the state hospital is because the jails have taken over it. So everybody coming in with a criminal charge will go to the state hospital, and they're the first priority, which is taken over, and there's not even enough room for them to get them through. There is a bill, I don't know if you know this, the DA's office is trying to make the jails as the restoration for all these individuals.
How do you feel about that?
we won't be able to do it. Yeah, you know, we haven't talked, so.
I assumed I knew your answer, but.
Let's talk before it goes in the notes.
Fair. So
I
anyway.
have a lot of opinions. It's just crazy.
It's a big, big issue. It's probably the biggest issue we're grappling with as a state, is how to manage individuals who've committed crimes, who are so mentally ill that they really can't understand what they've done. And there's these two systems are colliding and they don't overlap very well sometimes. Okay, I'll move on because I could talk about that all day. Legislation, I don't have a ton of updates other than the revenue forecast came out on Wednesday and it's terrible. And that's very concerning for me. So it was like $700 million less than what they thought it was going to be, which means that all the 530 something bills that are sitting in Ways and Means are all going to be fighting for money that is significantly less than what we thought we had available. So that puts everything at risk. It puts our workforce package at risk. It puts impacts funding significantly at risk, which is a huge one for our community because it, as you know, funds the stabilization center. And it puts also just the investments we were hoping for aid and assist, civil commitment, and crisis at significant risk. So I don't know what's going to happen. We'll be happy to get anything at this point. I am hearing capital construction requests actually have a better shot of getting funded because they're from lottery funds versus some of these other funds. So that may mean we get the child psych facility dollars if it's approved, but everything else is pretty competitive and at risk. So we'll know when you know. We're advocating and writing letters and doing all the things. I think at this point, it's just in the hands of the deciders on Ways and Means. Do you want me to get into the local plan at this time? Okay.
Yeah, because that'll set up our next agenda item.
So as part of the contracts with the state, there is a new, well, it's not new, it's actually always been there, but we used to be allowed to be able to use our regional health improvement plan to meet this requirement. They're not going to let us do that anymore. So going forward, there's going to be a requirement for a local plan that's created by behavioral health that has to be coordinated with a number of entities, all the typical players in this field. So a lot of overlap with the regional health improvement plan. We'll be able to inform it using some of that work. We don't have to duplicate it, but we'll have to write our own plan. I was talking to Melinda about this, and I think there's a real opportunity for this board to be very active in that process and to help and help whatever so the local plan really needs to set our priorities for our community. We are given a bucket of money now in this new contract. Let me back up a second. Our prior contract used to give us money for about 100 and some odd different specific programs. And each program had its own requirements, and you could only spend that money on that program. We have negotiated that we are going to blow that up, and it's going to be 6 core areas in which we are funded for. So they're going to give us the money in one lump sum, and then we apply it to those 6 core areas. And some of them are like forensics, crisis, outpatient, kind of what you would think of for the typical core areas.
Can I interrupt? Is that something that you welcome?
Yes.
Doing it that way?
We're excited about that. We've found some unintended consequences in this process, as you do with any change. They have prioritized certain populations within this. So essentially, we have to prioritize aid and assist, shockingly. And so aid and assist, crisis, civil commitment do have to be funded no matter what. And there's no new money. So it means that we're going to have to prioritize. There's going to be money coming out of other places, which we've been fighting against. We're not done with our negotiations, so there's still room for improvement on this. But as we create our local plan, we need to create our priorities. When I talked to Melinda, my thought was, we have to have this done by October 1. We don't get the final template until July 1. So we only have 90 days to get the first draft in, but we have till December to get the final thing in. So my proposal was that we would quickly get our draft in to meet our requirements, come up with the draft, but then after it's submitted to the state October 1, bring it back to this group after we have a draft for you all to look at. We also have to identify gaps and need, because there's not enough funding to go around. And so I thought we were talking, and that could really help inform your strategies as a board of what you want to work on potentially as we identify these gaps. to think about strategies to improve this. Because I have to outline in the local plan, what are our strategies to actually fix this problem or work on this problem. And so that's where I think the board could be really helpful if you all are open to that or interested in doing that. And then we could work on that from October to December together.
When you say negotiating, it's with the Oregon Health Authority, right? Okay. They pretty much dictate everything.
With DOJ. Yeah. OHA is definitely at the table with us, but the Department of Justice attorneys are the ones who represent the Oregon State.
Oh, okay.
Yeah, and so they are the ones that were, I feel like, really negotiating with this.
And county council is.
County councils are heavily involved in this process as well. So it's a true contract negotiation that affects the entire state.
So it's a state issue. It's not just Deschutes County negotiating. It's like a coalition.
Well, it is Deschutes County. We collectively negotiate. At the end of the day, each county makes their own decision about whether they'll sign or not.
Okay. Is it one of those things where whether you sign or not that's not my question, but is whatever is proposed, it's the same for every county?
Yes.
Okay. Wow.
Yeah.
I'm glad I don't have that job. That would be hard.
It's not yeah. I feel like I've been negotiating the contract for 5 years now.
Any other questions for Holly?
Well, circling back, so what are you saying that would be helpful for us to help with?
So as I said, we have only 90 days to come up with a quick and dirty draft local plan of how we're going to prioritize the dollars in these 6 core service areas. So I don't know that I'll have time to have you all part of that process, and it is just a draft. So I thought we would get that done and then bring that draft back to this group for sort of review, input, ideas, also helping identify where the gaps are within that plan of things that this board may want to say, gosh, it really looks like prevention isn't funded in the way that we all think is really important because we had to prioritize these other things. What are we going to do to make sure prevention is happening? What are we going to do to work on prevention activities? Or that's just an example. It doesn't have to be prevention. Could be some children's services. It could be that we've had some of our outpatient services don't get prioritized in the way that they've had. There's a number. We only have so much money, and with them requiring us to prioritize civil, aid and assist, psychiatric security review board, and crisis.
Are those among the 6?
Those are there, but they're populations within the 6. We have to prioritize and make sure the requirements for those priority populations are met. And we already know going into the contract that those services are not fully funded. And we're not getting any more money. And unless we get an infusion from the legislature, which now I'm not assuming we will. So there's going to have to be some prioritization. I don't know that we're going to be in a position, to be really frank, that we're going to be drastically underfunded in any one area. We're pretty resourceful. We have reserves. We have some other mechanisms we can pull on lever. We have burn funding. So it's not quite as dire as it sounds. I think there will be some areas in which we'd like to see be more robust. But we won't, I can't see there really being an area that we're not doing that thing. We're not doing prevention at all, or we're not doing outpatient at all. It's more of I can't do as much of it because we don't have the money to go around. So how would this board inform that and then maybe think of some strategies to help improve that going forward? Does that make sense? I know it's kind of a lot. It's a lot. This is kind of all new. So,
anybody else have any questions for Holly?
I'll just add, we've been going through a certified community behavioral health clinic needs assessment right now too, which mirrors this local plan a lot. And so a lot of people from our department have been working on this community needs assessment. I think it's 50-some pages at the moment. Yeah. And it again covers a lot of the similar stuff. So we will be using that as well to help inform this local
100%.
There's a lot of, again, similarities. So just know that will help, I think, your draft. And we're close to being done. Close to being done. So that way you can have that as a resource too, and the board can have it as a resource.
That'll be huge. Yeah, we're gonna use everything that we've done. There's so much overlap. They make us do so many plans and so many needs assessments. It's really shocking if we were to list them all out for you and the work that goes into creating these. So we're going to try and not reinvent the wheel on this, but I do want it to also be a meaningful document of how we fund and prioritize services for Deschutes County. And that feels like a really great place for this board to be involved in that discussion and advising us on that. I mean, that's really that's kind of, it feels to me like what you were designed to do, really, was to help us with that effort. So.
Kind of a metric question. How, and maybe very robust, are the different metrics around cost and benefit on prevention versus down the line, how much more? Do you have good, robust metrics to go to war with yet?
Oh, so prevention is handled really mostly on our public health side. We actually pass the dollars through to our prevention team on the public health side. Not all CMHPs do that. And so they have lots of information and statistics that demonstrate that the work that they do really prevents worse, downstream effects of bad outcomes. We don't have any necessarily built-in metrics into our county financial assistance agreements around prevention. Not to the level you're talking about. There'll be something like making sure we do certain activities, but not anything around outcomes related to prevention. We do have outcome metrics we haven't seen the final drafts yet, but there will be outcome metrics associated with our CFAA this time around versus a bunch of check the box things that say we did these certain things. They're going to try to move towards an outcomes based, but again, some of what the state cares about right now is outcomes related to how many people we're keeping out of the state hospital for aid and assist. How many, so it's our desired outcomes aren't always the same.
Okay, so there's still big opportunity, maybe not this year, to take a look at the cost of doing something and the cost of not doing something, and the long-term increased costs.
Oh, yes. I mean, I've been trying to do that with the stabilization center for years. It's really challenging. I mean, especially as a therapist. And as a behavioral health entity, there needs to, and I've been pushing the state to do this for a long time, to really talk about what is a true cost savings of somebody who we prevented from going into the criminal justice system. We prevented from overdosing. We prevented from dying by suicide, prevented from going to the ED. I can get a couple of base numbers, but it doesn't really tell the true story of what improving somebody's quality of life saves the community long term. I mean, the tentacles are endless. And I think we shortchange ourselves often when we are trying to just put a quick number of we saved this many hours of law enforcement time, or we saved this, it doesn't tell the whole story.
I would imagine though that there's national studies and metrics that have looked at this.
There are, but they're not great. I got to be honest. Stabilization centers in particular are fairly new-ish in this way that we're doing them. So I think it's still emerging. We know what the cost of saving somebody from going to the emergency department is for somebody with mental health conditions. I mean, we can get that number.
And every state does it differently. So you can't do apples to apples. You just can't do it.
Yeah, and it doesn't quantify, okay, so they didn't go to the emergency room. They got help instead. We helped them get a job. They got their children back. They how do you quantify?
We got health insurance,
health insurance, and they're they're paying tax. I don't think anybody's done sort of the massive trickle down effect of what it means to get somebody the quality of life back.
I think it would be an astonishing amount.
It'd be enormous.
A behavioral health person may have some metrics that could be translated into dollars, not just numbers, but dollars and prevented dollars and all rolled up. What a great dream that would be to do that.
Yeah, we know we're saving the healthcare system in general about $800,000 a year. So that's a rough estimate of just an emergency department diversions alone. So, I mean, that's just one number. So anyway, I'll stop talking. Questions about kind of more to come, I think, on it. It's not fully developed yet. We're still in negotiations.
Going on. So that kind of leads us into the next agenda item, which is Lee introduced kind of our initiative to try and figure out our board strategic priorities and how we're going to focus sort of our efforts and our attention. And so we had planned to try and collect your input. I think there was a request for some emails, about, here's a list of, priorities, just throwing everything at the wall that we could. And that we would organize ourselves to try and establish those priorities, maybe on like every 2-year basis, or maybe it would be a strategic priority list of like maybe 3 priorities for the terms of the officers, or some period of time. But given that what we have learned from Holly about the OHA requirement for the local plan that's based on 6 core service areas and gaps, Lee and I talked with Holly about, does it make sense for us to perhaps pause our work on establishing our strategic priorities until we see the draft plan that will be available in October, and then we do that work with Holly and her team October, November, and December to help them finish up a final draft, get our input, because it really does, she's right, that really aligns with what our purpose is, which is an advisory board, and our mission is to advise the department and advise the county commissioners and kind of be a liaison there. And so I think that I don't think it's something that we need to put to a vote, but I just wanted to let you know that that's what we are proposing to do, is to pause that work on strategic priorities for now and sort of sweep into that local plan and have that launch our discussion on that.
Actually, that sounds very strategic to me.
It's a strategic decision to not talk about our strategic priorities right now.
What could be more strategic than helping them create a return on investment scenario, even if it's a few case studies rather than an overall population study? What could be more strategic than justifying the huge amount of dollars that could be saved by doing it right and doing it well? To me, that's big.
And I think it flows a lot from what we've worked towards in some of our collective conversations about why we're here. A lot of us are in the field, but lived experience is what we all talked about, and how we will get to know you, right? And how do we embrace those folks? We thought about internship ideas. We thought about this and that. Bringing that to voice to talk about, well, Holly, here's the problem with that, or here's the really cool thing you could do with the minimal dollars now for that. Whatever you got, we can bring in conversations, and Linda, from your work and Stephanie's work, that we can bring more in that we maybe haven't always had the agency or the awareness to talk about. And yeah, also as far as strategically planning, we're not talking about strategically planning. We don't want to throw the dart at the map and at the same time, as far as that goes, and to really be collective and collaborative. It does feel like the right thing.
So unless there's any real objections to that, it sounds like there's consensus that makes sense to sort of pause our strategic planning pending the local plan review and assistance on that. Any other discussion?
Well, I have a question for Holly. Holly, what, including the behavioral health, how much money do you think we're spending in Central Oregon on behavioral health related issues?
Oh my gosh.
Outside of the private sector.
You mean just in the public sector?
Yeah.
I mean, I wish Molly were here. I can't even speak to what St. Charles spends on behavioral health. I mean, they run some of the most expensive pieces of the behavioral health system. The jail spends money on the behavioral health system.
Well,
Probation and parole spends money on the behavioral health
So
system.
I'm suspecting it was a complicated answer.
It's a very complicated answer. I mean, ours is $67 million just here. So, I mean, it's a very, very large number when you collectively think about what all of the major players in the public behavioral health system are spending. So it's huge. It's a huge number. That's what I'll say. I don't have the exact number because I don't know their budgets.
I have a strange question. probably a stupid one. Is there any, can't think of the right word. Is there anything to the fact that the states, based on their political, which way they lean, are red states or blue states recognizing and spending more money on behavioral health than the other states? I mean, is there a big gap between? Yeah, there is, huge. Yeah. Okay.
Yeah, there's definitely a gap. I mean, I feel like we've had I'll say though, I mean, we have been massively underfunded in Oregon for a very long time, hence why we are often ranked 49th on the list of access to behavioral health services. I think there's still challenges here, but they have made some strategic, robust investments in behavioral health these last, I don't know what, 5, 6 years, 7 years, 6 years, with rate increases and large investments and all the things, but it's been a catch-up game.
Yeah.
So we're still we're just catching up, and then there's a new issue. So we're never quite at where we need to be. It still needs a very robust investment. You know, it kind of depends on the state too, because some states are state-run behavioral health systems. Others, like Oregon, have local behavioral health systems and everything in between. So the dollars stretch differently in those different states.
Okay, so our conversation about, our mission and our role here kind of is a great segue into a continued discussion about the purpose of the outreach committee, of which is constituted Julie and Linda currently. And so I'm going to turn this over to Julie. Is that all right?
Yeah.
To kind of, we sort of had some thoughts.
Sure. And Linda's, I haven't had a chance to get with Linda, so then I'm going to catch you off guard.
This is all very new this
I'm
week.
not going anywhere.
Yeah, okay, so this is all very new, and Linda's, stepped up to be a part of this committee, so I apologize, but I'm excited that you're on the committee. So the feedback that we got, because when I kind of blasted it out at the last meeting, it was just like, who are we? What are we doing? What is this committee's purpose? And it has been determined, it's just based on all the feedback that we did get, that what outreach means, what we're going to define this outreach committee as is people from this committee, not the board, unless board members want to step up, which I would highly encourage to help with the effort. But the committee going to strategic partners, going in with a mission to not only learn about who they are, what they do, who they serve, a little bit about them, kind of like I did when I went to the Lighthouse, but taking it a step further and saying, okay, thanks for all that information. I'm going to take it back to my board so that they're informed about your information, about who you are. But as a leader in this community with young children, what are your biggest obstacles? Where are the gaps? Same term you're using. What do you need the most from the county? And I mean, if you could have anything, what would it be? And what are the biggest barriers to your success? Maybe even, where do you hope to see yourself 3 years down the road from now? What's going to prevent you from achieving your goals that you've set for yourself? And then bring those back. Let's just pretend it's me that goes out to, I'll just use the stabilization center as an example, and asking all those really well thought out questions and being consistent of the questions that we ask of every single agency, and then coming back and saying, happily type it up and say, okay, I went to the stabilization center. Here are the bullet points, very quick. We don't have a lot of time. Here's who they are. These are the things that they identified as their biggest barriers. And then we had this interesting conversation about this one particular area where the biggest gap is and where they need the most help. And then do that consistently. I was thinking, Melinda and I were thinking once a month, but because the sense of urgency and because you need to put this report together, wouldn't it be great if we could do 2 a month? I don't know, that might be too aggressive. It doesn't have to be the same person every time. It could be Linda 1 in 2 weeks, Julie in 2 weeks, maybe 1 volunteer from the department 3 weeks later. So we're getting in a few more than once a month. And then the whole committee, the whole BHAP committee here is what's happening in our community, our health and substance abuse committee. We should probably include those agencies too. And boy, these 3 are really sticking out as areas that need the most attention, the most money, the most help. And then providing that, and, you know, Holly's here to hear every single one of these, or her, you know, assistants when she's not here, and it would help you with your efforts. But also with a commissioner on the board hearing this at the same time, that's really truly what it's determined that our role is as an advisory board. Let's advise Holly and her team, so she can do her reports. Let's advise the commissioners and say, we did all this homework over the last 6 months, and this is what we learned as a group. And here's the information, and here's where we went, and here's what they said, and here are the bullet points of the, you know, the wrapping it all up into a nice little package. That's what we can do. And so I think that's what the outreach committee needs to be. I'm happy to go do those meetings because I'm learning a lot as I go. I kind of did that with the Lighthouse, except I could have asked a lot more questions. It shouldn't be a hardship on any of the agencies that I've listed, because a group of 10 people walking through is a much bigger deal than one person saying, you know, can I take 20 minutes of your time, and I've got my questions already written down, and then bringing it back here, hopefully it being a 2-minute, you know, recap, giving Holly the notes, and then moving on to the next one and having another one 2 or 3 weeks later. So by the time October rolls around, you know, maybe we've made it to 10 different agencies.
And it would help probably for Julie and Linda if you guys have, I think connections. Well, connections, but also like we need to establish a list, you know, a running list of what agencies, what community partners, you know, maybe it's the Veterans Outreach or ECOVA, or, you know, it's a school district, or, I mean, we can have a large list. But if you guys have some ideas, you know, that you want something added to the list, it might already be there, but just send them to, I think, Julie and Linda. Say, hey, why don't you add them? And if you have any connections to those, you know, some of them we may need to have a facilitator or an introduction of some sort of thing. I think that would be helpful.
I think I'm going to send a list to, because I don't know if I have the actual accurate email list, but I'll send it to Dana. I'll work on it in the next week. I've probably got 20 to 25 agencies that just kind of came off the top of my head, but I know I'm missing some. And I know I'm missing some of the substance abuse ones, which I think we need to incorporate in there. That just helps that whole effort. And just please take time to look at it and say, you know what, this one's missing. We missed the veterans. We missed the seniors. We missed the whatever population. Don't forget them. And then we'll take that, and Linda and I will start ticking off which ones we're going to go do. And if anybody has a connection with somebody, or you know, like, I mean, you have so much information on the jail, you know, we wouldn't need to have somebody go to the jail necessarily and have that meeting with you. But you could.
Yeah, but a tour would be nice. I mean,
yeah, I'd love a tour. So yeah, so anybody who wants to jump in and help with that, or take one on and say, I know somebody, I could do that really easily. I've got 20 minutes in my schedule in the next month. It doesn't have to be on a schedule. Just tell me you're doing it. Let me know where you're going, and then let us know so we can get you on the agenda next time, and we'll carve out, keep it short, like 3 or 4 minutes of these are the places we visited. And then how powerful could that be, not only for the commissioners, but for Holly when she's putting everything together?
Yeah, that would certainly be great. The one thing I would say, that just so you don't duplicate some efforts, is the Regional Health Improvement Plan. Has a list of bazillion community partners that are involved in that process. And there are, I just make sure, like I would do a deep dive on that. It's online, it's on the Central Oregon Health Council website, because what their goal is to do some of what you're talking about, I think at a much broader level.
Sure.
So this would be more granular, probably more useful in some
Whose
ways.
website?
Central Oregon Health Council.
Oh, sure.
And it's the Regional Health Improvement Plan. And it lists, and it's a process they go through every 5 years. Something like 3 years, something like that.
Yeah.
And they just went through it. And so it really does identify for behavioral health, for physical health, for different segments of our population, but the gaps and some of the things that the community partners are saying around all of this. So you may just want to take a deep dive into that to make sure any questions you're asking aren't already been answered in that document.
Yeah.
Kelly just put it in the chat so I can send that to you
Oh,
as well.
Thanks, Kelly.
I have a question.
I have a question, and maybe I've missed this, backing up a little bit. Is the intention behind this for relationship building or for us to learn more about these agencies? Or I guess I'm missing that.
The primary
Does
purpose,
the county already have all of these relationships built?
no, but I believe, and Holly or Melinda, correct me if I'm wrong, the relationship building will happen and the knowledge will happen for this group. The primary purpose is for us to be able to advise the commissioners and help Holly with all the tasks that she has to do, and identify. Our purpose is to identify where this county needs the most help, and we are an advisory board first. That's who we are first. So if we can collect information that's specific to our county and give it to the commissioners and give it to Holly, then we're doing what our mission is, which is to advise those people who can do something with the information. So this is not about going out and making friends. It's not about, educating all of us here, although those things will happen. It's about providing advice from this board who has all this knowledge and has been out in the community gathering more in current day times.
Trying to understand the barriers.
Yeah.
The barriers people and the community agencies are experiencing and accessing behavioral health services, and having that be driven from the community versus us telling you kind of what our barriers are, but having the community share what their barriers might be and how we might start to work on those, I think.
So bringing it back to the bylaws, we have 6 delineated functions for BHAB. And we've talked about this before with respect to our flyer or whatever. But I think this work fits into at least 4 of those functions. One is to listen to and learn from people with lived experience. So that's maybe maybe it fits somewhat, but maybe not directly, I don't know. And then to enhance community awareness of the advisory board, I think definitely, it's not so much relationship building, but I think when we meet with the community agencies, directors, then that just enhances our visibility to them, so they know that there's some place that they can go if, to talk about what's happening in their world, to participate in periodic program reviews and site visits by state agencies and grantors. I don't know why it's by state agencies and grantors. I see that as us. I mean, it feels like it's worded weird, but I think that it fits that.
That's when they've come, state agencies have come and they've been meeting with them, and it's one of us sits in on that. That's what that is.
Okay. The audits.
Oh, okay.
Yeah.
So that's kind of different, but.
Okay, that's, and then one is to integrate the regional health improvement plan into advisory board work. So this is making that connection. Yeah.
That helps to understand it, because I don't want it to be that we're going to learn about these different organizations and then directing the county, oh, do you know about these folks? It's more getting into who's there, what are they facing right now?
What are your obstacles?
Kind of taking a pulse of things.
The other thing I would say, and I don't know how Holly feels about this, but what we've talked about is, in my list, is all these agencies and agencies mainly, and organizations and facilities and those kinds of things that are out there. And from a person who's very heavily involved in NAMI, who has a family member who has gone through the system with lived experience in mental illness, I have access to all these NAMI people, NAMI people, whatever, NAMI, I can't get it correctly. We have all these support groups, and I would love to go to the family members who are, I'm one of them, and I go to those support groups, and I already know what they're going to say. They're going to say, we don't know what's out there. And, so that's going to be a big, huge one if we want to include that in there. As we all know what the resources are, or we're all learning about them, but the person who's working 50 hours a week with a young person at home who can barely keep their life moving forward, they are not aware of what's out there, and they're struggling. Those people don't know what's available to them.
Well, it's so true. I saw that in the regional health improvement plan. When I looked at it, I was so disappointed in part of it, because it's one of the statements in there was about how we have no crisis services here. And I was like, what? Like, we have some of the most robust in the state here. But what that told me is that whoever was being spoken to, the people that were being talked to out in the community, they don't know. And so this could fall, as I think about alignment with the local plan that we're going to be creating, of like prevention, like, prevention and promotion. Like, how do people know what exists out there, and what are some strategies that we could do to make sure everyone, not just people that are ending up in the PES unit, know what's available, but people more upstream can know what services are available to prevent them ever having to end up in the PES unit. So that, I think that.
And I think that's kind of what NAMI's purpose is awareness. And we just got a $20,000 grant. We found out last night, anonymous.
Oh, wow.
So, yeah.
And she's been rocking it.
I didn't have anything to do with that.
Yeah, but let me just brag on my friend here.
You always do.
Kicking butt, taking names.
No, anyway.
I mean, they weren't doing any fundraising, and now I don't know how many thousands of dollars.
Anyway, NAMI's out there just really trying.
I applied for another grant for the mobile. I wrote a letter of support for.
Oh, did you? Yeah. So Casey does a ton of that. She does most of that. So it's probably a Casey thing. But I think people are finally recognizing that it's everywhere. And when they read our brochure that says 1 in 4 adults have mental illness, and now we're going, all the people who were sponsors, we're now going into their organizations and volunteering to go in and do a presentation about who we are and what we offer. And then not just what we offer, but what we know is out there and available. And the organizations are like, yes, please come talk. We'll have an employee meeting, or they just want us to talk to their leadership team, So getting the awareness out to the layman, the people who aren't involved in these kinds of things at all. I think those people are underserved. I do, for sure.
And so I think that there's more conversation about outreach committee, but I think for right now, that's a good focus to start with. And then we can kind of, in future months, sort of revisit the first part of the first function is to listen and to learn from people with lived experience. And then we can add that, that committee is going to need more help. So if you would like to be on a committee, please think about joining Linda and Julie on that, and spreading the wealth.
And just remember, I'm very sensitive to everybody's time here. I know everybody's working, everybody, maybe has family, and time is precious. I'll never ask somebody to do something they don't want to do, but if somebody says, you know what, I can take that one, I've got 20 minutes to carve out, we'll take the assistance. You don't even have to be officially on the committee. You can just say, I can do one or whatever, but that's all. So.
All right. I thought it was great when you sent out that email of like, hey, we're meeting here, come if you can. And I think that would be really helpful when you
send that out and just let people know.
Yeah, just with your next thing. And I think the more we have members who see those will start participating and getting a little more engaged.
I will tell you, I learned so much. I learned so much, across the board in every way. And what I took away from there, I'll just be very brief, is the people who were working there, I was like, you guys are amazing. They were ambassadors for these people. They treated them like they were guests of a hotel. Hi, Holly, how's your day? How was work today? And I was just like, gosh, you could be in the hospitality industry at my desk, And so I was really, I'm really impressed with the people who do this kind of work, so yeah, it's a great thing. So I'm done. Sorry, I went over my time again.
So there's further discussion on that. I wanted to move on to our next agenda item, which is upcoming events, and this is open to all board members. But before we open up that discussion, Lee and I have talked and what we are proposing, and I don't think we're going to submit it to a vote. I think that is within our discretion. Hopefully but we want to hear your input. Is that we'll keep the June meeting as is. We will skip the July meeting because it's a busy summertime and probably attendance might be low. Have the August meeting, but for June and August, reduce the time to 1 hour instead of 1 5.5 hours. I think we might be a little bit light on stuff to do until we get Holly's draft local plan. We could always switch and have the July meeting and take August off. I don't really care either way. But that's sort of our proposal coming up for the summer. I think last year we took off a month or something.
We took August off last year.
Yeah, so if you guys are on board with that plan, and then the June meeting will have somebody speak to us a little bit more about the co-occurring substance use disorder with behavioral health issues, just so that we can really I needed to internalize that because I'm not in the industry, so I'm still trying to understand that. So if you guys think that that's a decent plan, and if you have any input as to whether you'd rather take July or August off, doesn't matter to me.
Just a question. Timing wise, this is horrible, I'm sure. And I'm not trying to do more meetings. Would it be at all useful to you at that time, too early or too late, to have kind of a big brainstorming session about what else we can do to help you build what you're trying to build to sell what you need for your funding?
Yeah, it's not about selling it. So essentially, I mean,
Sorry,
it's okay. I want to be clear what the local plan is about. It's that we get the money. We're going to get the money that we get, the same money we've always gotten, no more, no less in theory. And we need to, our plan is to drive how we're going to budget that money. And so, and we have to say why we're going to budget it that way and what our local need demonstrates as to why we're budgeting it that way. So I don't think I know, like, I've been in a bazillion planning sessions over the years, and I think between all of my managers and we know where our core issues are. We know where our pinch points are. We know where we have to prioritize. So I think we're good to be able to get a draft together. Where we're going to need some help, is really on what you all and maybe your outreach determines are some of the gaps that maybe we hadn't thought about, or that maybe weren't necessarily gaps we thought should be prioritized, but our community thinks we should prioritize, or you all think we should prioritize. So that's where I think in the nuances and the details that you all will get will be very valuable. I think in the overall arching thing, like, we just got some stuff that we know we have to do, and I don't think we need to spend your time doing that part.
And Holly, if I understood you, and just so you guys know, Lee and I meet with Holly and Dana mid-cycle just to kind of have a pulse on what she needs, and we brainstorm with her a lot about how we can support her department as well as be an asset and a resource for the commissioners. So we're actively talking to her, and that's kind of driving some of our agenda items that we put on every month. But if I understood what you shared last week, the funding model is changing from OHA. And so instead of OHA sending grants or dollars targeted to specific programs and services, they're now proposing to give you more of a bucket of money as long as you do this local plan and identify the 6 core service areas or prioritize those and how you're going to do it. Is that right?
Yeah, pretty much. Yeah, there are 6 core service areas, and within each of those core service areas, there are some prioritized populations that fall underneath it that have to kind of be adhered to. So each area is going to need to have something. And then it's just kind of how robust each area ends up.
Prioritize and the hydraulics of each.
Holly, if a group that has in the past gotten attention and money from you guys, one of those 18 or whatever you said, and one of those groups does not fit into the 6 core anymore, does that mean they'll
all fit into the 6 core, because what they did was they took everything that we had been receiving and they put them into the 6 core area. So nothing's getting left out. We have to do all the things still. It's just kind of bucketed differently. But to your point, though, there have been dollars we have contracted out in the past because they were so specific to such a small population that we were like, it's not worth it for us to do, and this group can do this niche thing. Those are now not going to be required to do that niche thing. They can come into the larger bucket and fall into the area that we need to provide. So we may be ending some contracts and thinking about doing contracting differently now that the dollars are more flexible. So in some ways, it does give us a little more money in that respect, but because we have to prioritize things, it's going to come out in the wash probably.
Correct me if I'm wrong, the CJC, who gives all the money to all of us for like my deflection program and things like that, Criminal Justice Council, they were unable, from what I was told, they were unable to manage all these different pots of money. So they're just saying, let's just give them, let them.
This is different. This is OHA that is I'm talking about. So OHA funds us. Criminal Justice Commission, we have grants through them. And what that legislation you're talking about is there's all these different grants that CJC was managing. The legislature is trying to consolidate that into one application. That's
So
different.
that's coming down the pipe.
That's different, yeah.
Okay, so we're at 129 now, so we need to adjourn shortly. Does anybody have any input as to July versus August to take that month off for our BHAB meeting?
Now's your time.
Yeah. All right.
Flexible.
If nobody cares, then I think we talked about July.
Yeah.
And then we can revisit in August, and that'll help us segue into the fall. Okay, so you guys have that in your calendar, no July meeting, and June and August will be an hour, not an hour and a half. And we will resume for an hour and a half, starting with September again. That'll probably be a pattern that we might follow on an annual basis, but we'll see. And then I think, I know Julie has another upcoming event to announce, and if any of you guys have any, this is the time.
NAMI's fundraiser is Sunday. It's going to be nice and sunny and warm on Sunday morning with rain.
I was like, is it?
So it's at Pioneer Park. It's at 9 a.m. We know our numbers are going to be low because of that construction. It's going to be a real problem. It's going to probably hamper people from coming because they might have a hard time finding parking spaces. So spread the word. If you want to come, we'd love to have you, probably a smaller group. If you can't come, but you want to donate, just go to the website. There's all kinds of ways to donate. But otherwise, I think we're gonna, at the end of the day, I don't know, we're maybe close to doubling what we did last year, maybe, but it's a long process, the sponsors and donations and the teams and the individuals and then donations at the actual event. And then we still get trickle in from after the event, but it's the numbers will not reflect it, I think, at the walk, and I think it's going to be crummy weather. So I don't expect to see any of you there, but feel free to donate on the webpage. Thanks. 9 o'clock, Pioneer Park.
Any other upcoming events